Today we're going to break down hypovolemic shock, and by the end of this video, you'll know the causes, the exact pathophysiology, the hemodynamic changes, and how to manage it like a pro. Let's get started. First, what is a hypovolemic shock? It's a type of shock that happens when your body loses a significant amount of intravascular volume. This reduces venous return, which means your heart has less blood to pump out, cardiac output drops, and as a result, tissues don't get enough oxygen. Now, what actually causes this? We split it into two big categories. Number one, hemorrhagic causes. This means blood loss. Think trauma, big GI bleeds, surgical blood loss, or ruptured aneurysms. Number two, non hemorrhagic causes. Here, you're losing fluids but not blood. This can be from severe vomiting, diarrhea, burns, excessive sweating, or fluid shifting into third spaces like in peritonitis or pancreatitis. Let's talk about pathophysiology, the chain reaction that makes this so dangerous. When blood volume drops, preload, that's your end diastolic volume, goes down. Less preload means less stroke volume. Less stroke volume means less cardiac output. That leads to poor tissue perfusion. Cells switch to anaerobic metabolism. Lactic acid builds up, and you get metabolic acidosis. If you don't fix this, organ failure kicks in. In terms of numbers, here's what you will see in a hypovolemic shock. CVP is low because there's less volume returning to the heart. PCWP is low, same reason, low preload. Cardiac output is low, the pump just doesn't have enough to pump. SVR is high. This is your body's compensation. Vessels clamp down to try to maintain your blood pressure. How does the patient actually look? They will be hypotensive with tachycardia. The skin is cold and clammy because of the vasoconstriction. The pulse weak and thready. Capillary refill is delayed. Urine output drops, that's oliguria. Now, what are the compensatory mechanisms? Your body just doesn't give up, it fights back. Sympathetic activation cranks up the heart rate and clamps down vessels. RAAS kicks in, renin-angiotensin system, retaining sodium and water to boost volume. ADH secretion goes up, which will hold on to the water. But here's the thing, these are temporary measures. If you do not replace the lost volume, they won't save the patient. How do we confirm and assess? CBC to check hemoglobin and hematocrit, electrolytes and lactate. High lactate tells you the tissues are starving for oxygen. ABG will show metabolic acidosis. Ultrasound or fast scan in trauma. Endoscopy if you're suspecting a GI bleed. Now to management. Okay, the most important part. Step 1, secure the airway and give oxygen. Step 2, fluid resuscitation. Start fast with isotonic crystalloids like normal saline or lactated ringers. Step 3, if the cause is blood loss, don't just give fluids. You need blood products, packed red cells, FFP, platelets if needed. Step 4, stop the source. Surgery for internal bleeding, cauterize a GI bleed, treat diarrhea or vomiting, whatever the cause is. And remember, avoid vasopressors until the volume is restored. Otherwise, you'll just squeeze empty pipes. And that is hypovolemic shock in a nutshell. Causes, pathophysiology, hemodynamics, and treatment. If you like this breakdown, hit like and subscribe for more high yield medical videos. See you in the next one.